speaker is Dr. Sarojini. She has been working extensively on the area of women's health and rights, and she is the founder of Samaj, the research group for women and health, and the coordinator of national level research on reproductive health, medical technology, and the two-child norm. She has also conducted a number of action research projects on clinical trials in Andhra Pradesh, Madhya Pradesh, tribal areas, and a study of health, the impact of health of the Gujarat riots and the riot victims. She is also the co-chair of the People's Health Movement at the global level. So welcome, Dr. Sarojini.
Thank you very much for giving me this opportunity to come and speak here. And thanks to Amit, because he set this tone. I will try to bring in the issues from the angle of gender, and then we can have a discussion later. I think most of the issues which I thought can be located in the previous presentation. So I will go straight away into the context where I'm trying to locate gender and marginalized sections. So here we have to talk about the structural inequalities by caste, gender, age, ethnicity, disability, religion, sexuality, and poverty, which not only exacerbate poor physical, sexual, and reproductive and emotional health for women and young girls, but also disadvantage them in accessing healthcare. So those outside the frame of families, like single women, lesbian women, sex workers, women in custody, and women heading households, are more likely to be excluded. Unless underlying factors contributing to inequalities are systematically addressed, we cannot talk about universal health care. I want to say universal health care, I'm not going to use the word health coverage. And it cannot be achieved, and what Amit said, health for all, which will remain a distant dream for us. So what do you mean? Like, I'm sure I'm not going into the basics because I'm speaking to an audience who are familiar with all this. Even now, the health system is limited by its understanding of gender, the binaries of gender, male or female. For example, like this is something which we have encountered, like working with the queer community, but there are no facilities for transgenders and others. Their special health needs also need to be factored in for the basic service package. Package, I want to put it in quotes. Health rights can be enjoyed by all and accessed at all times only if the rights of those who occupy low rungs in the gender hierarchy have secured rights in all spheres. So there is an urgent need to recognize and act towards inclusion and universal access. What I'm trying to do is I'm trying to raise certain issues and also come up with recommendations. I don't want to go into the rhetoric and also talk about the data here. One issue which I want to address here is about health infrastructure and healthcare. I want to pick up health facilities. Are they gender appropriate? Are they accessible to the groups coming from the socially disadvantaged and people who are coming from the tribal areas and culturally, like what I mean here, they're coming from the zones of conflict. And are they gender sensitive providers with whom we have in the healthcare centers? All facilities where women are meant to attend must have arrangements for privacy, enough women providers, gender sensitive male providers, and we do need clean toilets. I'm talking about the basic things which we do come across every day wherever we work, whether it is in urban or rural. And water, adequate water, and provision for waste disposal, including sanitary napkins. If you go and see a public health setup, this is a major issue which we do not think it is an issue at all. Universal health care, whatever right now it is, it excludes care for a range of health issues that are experienced particularly by women, differently by women. I pick up 4 or 5 here. One is the maternal health, other is malnutrition. I'll speak a little bit on the morbidities, which are reproductive health problems and cancers, gender-based violence, have in malaria, and that of all women such as TB needs to be added to skill-based attendance training curricula, which is missing right now, so that there is early detection and prophylactic treatment. Such deaths will also be left out of maternal mortality assessments. And what are the neglected health issues? Like early marriages and convergence with education, especially secondary education. Teenage pregnancies, safe abortions and sex education. We know most of the states have banned sex education in school curricula. We don't have much data on the cancers. Even now, like we are still studying what is the prevalence of incidence of cervical cancer in the country. We don't have the data. And we don't talk about menopausal problems and also prevention of osteoporosis. Infertility, which is the biggest issue right now in the context of medical tourism and commercial surrogacy. Uterine prolapse and fistula, like I want to add that here, and women's center safe contraception. And the orphan issues, non-specific aches and pains, not even counted in our data. Indicative of one is hunger, malnutrition, anemia, depression, anxiety, and violence, whether it is physical and sexual. Occupational health, all these are, we call it after the end of 19, refer them as orphan issues. And I would like to bring in here the two-child norm and the population control policies. Violence, how public health responds to it. Mental health, I want to give 1 minute attention here. Women suffer more from mental health problems not only during their reproductive lives, but also due to difficult circumstances in which many of them have to live. They are often prescribed the wrong drugs and not provided the support, counseling, and rehabilitation required. This is from a paper which I am quoting. As I mentioned, we don't talk about other genders at all. Here, in the context of UHC, the definition of maternal health needs to be expanded beyond childbirth in hospitals or institutions and include nutrition, weight loss entitlements, breastfeeding support in the workplace, and services for maternal morbidity. The approach needs to be one of maternity entitlements extending to childcare and creches. Access to quality maternal health services for marginalized communities. I'm sure most of you must have heard about the maternal deaths which happened in Bardani. And right now, an activist who was fighting on that has been arrested and she is in prison right now. This is a tribal belt in Madhya Pradesh, where more than 45 women died in the span of 3 months in a district hospital where they were denied or they were not attended at the time when they required attention. And that is something which is very important when we talk about universal health care. And maternal health in the context of surrogacy arrangements. This is something which I want to bring in here because I have seen in my own work, there were many maternal deaths happen for women who are going for the arrangements of surrogacy. Very recently, like I have documented one study in Ahmedabad where this woman was carrying, he is a surrogate, carrying twins for a commissioning in the US, and there was a delay, and then she died with cardiac arrest. It was not counted as a maternal death. It was eclampsia, which is a preventable maternal death. Those deaths were not counted in at all. And nutrition, I'm sure like this is something all of you are familiar, so I'm not going into the data. Food security and malnutrition are key issues of women's health and are faced during the entire life cycle. This must be a part of universal health care. And we need to ensure adequate nutrition for all girls, older women, and pregnant or lactating. The social determinants of health, which Amit spoke at the end, are critical where women are concerned and cannot be separated from health care. So when we talk about health or health care, we want to bring in social determinants. It's not just access to healthcare services. Violence, I want to spend a little more time here. I'm sure like all of us are like very much engaged after the tipping point incident which happened in Delhi last December. What was the response in general? Like poor recognition, look at the NFHSP data, even poorer respect, largely perceived as a law and order issue, even as a private problem. The serious linkages between violence and its health consequences are violence as urgently acknowledged, which is missing completely. Any of the document, you don't see violence or sexuality as determinants when you talk about health. Health system often the location of violence, which we have seen in our own work at most of the public health hospitals and private sector in Delhi and in Maharashtra too. Violations and discrimination that needs to be addressed. I am sure many of you working in the communities and in the sector must have seen this. Presently, very limited infrastructure to respond in a comprehensive manner to survivors, victims of violence. The health system, it needs to develop standard guidelines, protocols, and set up systems and procedures to respond to survivors of violence, whether within the facility or through its outreach initiatives. This does not necessarily imply a singular model, but standards that become necessary to ensure that the optimal quality care is provided to all survivors and to establish the accountability of the health system in doing so. For example, therapeutic as well as medico-legal roles, counseling, referrals, convergence of ministries, departments, training and capacities of healthcare providers in all aspects of response. A demand for guidelines for care across the healthcare sector that is gendered has been voiced repeatedly, and some efforts are currently being made in this direction. This will enable the necessary care and support by the health sector in responding to any survivor. In Delhi, now the two fingers test has been revoked. But in many places you still have the two finger test. I just want to talk a little bit on the medical curricula. Like this is something which has come up in one of the papers. It continues to propound extremely stereotypical and problematic messages about violence. The influences the system's response. For example, forensic textbooks that make assumptions such as big women cannot relate, etc. It's still there. I want to talk a little bit about two-child norm here. About 16 central and state schemes have the two-child conditionality in our country, which is very, very important when we talk about universal health care and also talking about the social determinants of health. You know, these schemes, I'll come back with analysis a little bit later, which are very interesting to observe. And for example, the Indira Gandhi Matritva Sahyog Yojana, IGMSY, it was launched in 2010 in 52 districts on a pilot basis to partly compensate for the wage loss caused by pregnancy and help women recuperate after delivery. It recognizes all women's rights to maternity entitlements and is not restricted to wage earners or those below poverty line. As per the IGMSY, each pregnant and lactating woman will receive Rs 4,000 in 3 installments between the second trimester of pregnancy until the child is 6 months old, on fulfilling various conditions that are aimed at ensuring breastfeeding and antenatal and postnatal health checkups. This conditional cash transfer scheme, however, this is the main point, excludes women who are less than 19 years of age and those with more than 2 children. So this is something which is very, very important to look at. First of all, a third pregnancy is not a violation of the law. In India, where the family is involved in reproductive decisions and the woman cannot take decisions about her reproductive behavior, she should not be alone held responsible for the number of pregnancies. The state is also responsible for ensuring that all the information and services from prevention of the third pregnancy are made available to the women before excluding women with third pregnancy from the scheme. So you can see a very clear violation here. While marriage below 18 is a violation of the rights of a child, how can the state further marginalize the young mother by not providing for pregnancy when she is in utmost need for care? The second is, I'm sure all of you are familiar with Janani Suraksha Yojana, the JSY scheme. I'm not going in detail of the scheme because all of you are familiar. It has introduced to provide cash incentive for institutional delivery. The JSY component is for promoting institutional deliveries through provision of incentives for pregnant women, a certain amount for institutionalized deliveries. However, JSY provides pregnant women a certain amount of cash assistance for institution-led deliveries for the first 2 deliveries only. What will happen to the third delivery? The third childbirth is ineligible for maternity benefit unless sterilization is agreed on, and fourth child onwards, no benefits can be given. So there is a conditionality for sterilization here, which is again a coercion. And the third is very, very important when we talk about malnutrition and food security and the larger determinants for nutrition or health. This is the National Food Security Bill 2011 NFSP. A parliamentary standing committee, 27th report of the Standing Committee on Food, Consumer Affairs and Public Distribution, and the National Food Security Bill 2011, while guaranteeing legal entitlements to the population at large, spoke about limiting the provision of nutrition to 2 children while accessing the National Food Security Bill in an effort to stabilize the population. So there is a very clear link with population control agenda here. There needs to be a recognition of the discriminatory and undemocratic nature of this norm from the center, which should repeal any schemes that imbibes a norm as eligible criteria. This is a statement from John Race, who is an ex-member of NSC. He warns against what he calls the dangerous illusion that conditional cash transfers can replace public services, since they are meant to be a complement, not a substitute. So recently, there was a lot of campaign which happened, in between, to demand the government to revoke this particular clause from the bill, and a revised GO on the removal of conditions related to the 2-child norm and age from maternity entitlements like JSCOT and NMBS by the ministry on 8th May, very recently, following advocacy by groups. But it continued for quite some time. It's only because of the pressure from the groups who are working on these issues on public health and women's rights and child rights and right to food campaign, this has happened. And what are the implications of this 2-child norm? One is it is disadvantaging and discriminatory norm. Incentives and disincentives create a model of greater deprivation of services and state support and violation of rights of citizens, violation of bodily integrity and denial of reproductive agency and choice. Further marginalizes the economically weaker and socially disadvantaged sections from participating in processes and institutions of governance, weakening their voices and representation. Why am I bringing the governance? Because we have seen in Madhya Pradesh in the past, like it has been revoked again because of the campaigns. Like if you have more than 2 children, you cannot contest in the elections at the local governance. You cannot contest as a panchayat level. So that has been revoked in some states, but it is still there in some of the states in our country. As a qualification for participation in governance, it begins commitment to democratic principles, amplifies the power inequities vis-a-vis caste, gender, etc. We have seen our own work and how it impacts women, particularly coming from Dalit and Adivasis, when you have this kind of scheme where you cannot contest in elections if you have more than 2 children. Poor quality of services in public health system has led to adverse consequences on women's health, the severe violation of ethical protocol and physical injury being widely reported in the context of these norms. I will go a little bit into health insurance, which Amit spoke because it's very important. I come from the gender angle here. Is it key to achieving universal health care? I have a question on that, and I don't like it. Universal health care increasingly being equated to and promoted through insurance model, which we heard from Azim right now, which is minimalistic, operates within a marketed private system of healthcare, and raises concerns about its furthering the possibility of withdrawal, dismantling the public health system, and promotion of corporate interests in healthcare delivery, which he spoke right now. It is also from our BHA document. Studies from Chhattisgarh, which Amit pointed out, questions the health outcome can access it from us. There's a model of private sector engagement in healthcare provision, which is also put in our booklet and which talks in detail about it. Insurance schemes, depending on their nature, social insurance schemes, community health insurance, micro insurance, etc., are also likely to exclude women and other marginalized. For example, schemes in formal employment spaces, women are mostly in informal sectors. Even if premium is small, may not be able to afford, access finances, make a decision in this regard. Further schemes may cover or provide services only for limited health issues. Narrow focus on maternal health services covered by prepayment schemes may exclude diverse groups, adolescent girls, older women, etc. A moral hazard, rendering more or unnecessary and medically inappropriate care, which Amit mentioned about hysterectomies which happened in Chhattisgarh. The central question about how health insurance for the poor affects the right to health care and its identified core contents of equity, access and utilization, financial protection and quality, it remains largely unanswered at the anticipated level of detail that is required to inform policy making. We just did an analysis of the insurance schemes from a gender perspective to be published next month. This is from that study I am quoting this. Studies based in India may not have adequately inquired into gender differentials, vis-a-vis access, impact, etc. Framing policies to expand health insurance without incorporating lessons available so far can only run counter to the goal of universal access to equitable care. I want to bring in even women as health providers here. Women health workers' roles within the health system needs attention, even in the context of universal health care. Role of women as nurses, ashas needs greater attention. For example, more security, better working conditions, and recognition. Women health providers, especially community health workers such as ashas, they carry maximum responsibility and accountability, paid very little remuneration, and receive limited support from the health system. So this is something which needs to be looked at. And in UHC, I think we need to talk about gender data, monitoring and regulation too. Indicators we need to develop, gender disaggregated data, it should be gender. Monitoring and regulation in public sector, private sector, and in PPPs, like for example C-sections, hysterectomies and sterilizations. Like there are many, every day you come across like the large number of sterilizations taking place in Bihar and other northern states, and increasing C-sections and hysterectomies. Use of appropriate technologies and the appropriate use of technologies. When I'm coming, I'll go a little bit back on the regulation of C-sections, even in our own work, looking at healthcare and surrogacy. Again, I'm bringing back an example, like more number of couples who are going in the context of infertility also, where people who are going for IVF or surrogacy, the commissioning couple demand for C-section deliveries. So if you look at the data, whatever we have right now, most of the deliveries are happening in commercial surrogacy or C-section deliveries, which is very, very important. Because these are the issues which we never focus. We only talk about certain issues, but we leave out. But these advancement in technologies will take over in the context of, the medical tourism industry or healthcare industry or run by the corporate sector industries. So this is something which we need to address when we talk about public-private partnerships and corporate health sector. And we need to use appropriate technologies, and we need to use appropriate use of technologies both. And participation of women and other marginalized in health planning and monitoring is very, very important, which is missing. Most of the times they have been decided in Delhi, and now everything has been decided. There is a representation of the community. This is of the policies. Like I give you one clear example here. Like I work on the issue of clinical trials right now, or on the issue of medical technologies. Like how the meetings will be held. Like, this is very, very important when we are designing whether it is universal health care or any health plan or any health related document. You will call for a meeting, or you put up a notification on the website which you never get to know when it has been announced. It will never be announced in the regional media. It will be on the ministry. You will announce within 40 days you have to give your comments. Who will get to know unless you are following? At the community level, do we have access to that kind of electronic media where we can access that every day and monitor what is happening at the policy level? There is a big gap between the policy and practice at the community. This is how the policy has been designed. And within 40 days, if you don't give, they will set up a committee, and the committee will be like 8 people whom they think who can be managed most of the time. And then you come up with a document, and then that will become a notification. This is a trend which I am noticing, which is happening particularly in 1 or 2 cases which I am involved in fact. So then either you go with a dilemma, are you going to be co-opted? Are you going to push your agenda? Yet you take a consistent movement and then participate. When you come back, then what will happen to the document? Whether your concerns will be incorporated or not. This is the same thing which will happen in any document if it does not involve the community and the actuals who are going to be affected with this kind of policy framework. I think that is something which is very, very important. And I want to end up here, again taking back the discussion. These are something which are missing in the UNC framework, which we need to talk about. Issues of ability, because disability will never feature in. We don't talk about sexuality. We don't talk about health in the context of conflict at all. For example, even the violence. And state-sponsored coercive population policies, gender-based violence. Recently, because of Justice Verma Committee or the Delhi thing, but again, what happened? Marital rape is not included in the document. And that is something which we need to look at, but still, it is an important issue we need to push in. And especially the rights of sex workers, transgender, HIV positive, and what kind of discrimination they face when they go to access the health services, which is very, even women in custody, in prisons, what kind of health care they do get, which is very, very important. There are many studies which are coming. I think that is very important to bring into the